Am I audible? Can I start the presentation?
Yes.
Good afternoon to one and all present here. I'm Dr. Asima Fatima from SRM Medical College, here to present a newborn case, hypoglycemia with metabolic acidosis in newborn, a treatable cause of IEM. Objectives of my presentation: I'm presenting a case report of hypoglycemia with metabolic acidosis, a treatable cause of inborn error of metabolism, evaluation of hypoglycemia in neonatal period, and glucose homeostasis and its biochemical aspects. So a 24-year-old Gravida 2, Para 1, with a history of death, conceived spontaneously, born out of third-degree consanguineous marriage. History of present pregnancy was confirmed by UPT after 45 days of amenorrhea, booked and immunized. First trimester was uneven full. Dating scan and NT scan was normal. Second trimester, quickening felt at 5 months. Iron and folic acid supplements taken. No history of gestational diabetes mellitus. No history of gestational hypertension. And anomaly scan was normal. In third trimester, she continued to perceive fetal movements well. Growth scan was normal. Family significant past history was a sibling death at 2022, a neonatal death at 48 hours of life. It was a term baby born out of normal vaginal delivery with a birth weight of 2.78 kg, small for gestational age, developed respiratory distress from birth and was started on CPAP and established full feeds. The baby had worsening of metabolic acidosis further and expired at 36 hours of life, and cultures were found to be sterile. This child had elevated lactate and ammonia during neonatal period, and TMS reports was sent, which was suggestive of query primary or secondary lactic acidosis with high proline levels, which was not conclusive of any specific IEM. Genetic testing was not done for this baby. This is the pedigree chart, which shows the affected baby and the elder sibling who expired on day 2 of life, and also a history of another neonatal death in their family. So this baby was delivered by term 39 weeks plus 5 days by normal vaginal delivery and had normal transition at birth with normal Apgar. Baby was shifted to NICU for regular sugar monitoring and vitals monitoring in view of previous elder sibling death, and initiated on direct breastfeeds. Birth weight was 3.060 AGA. On 42nd hours of life, baby developed respiratory distress in the form of grunting and tachypnea. Hence, the baby was started on CPAP support. Chest X-ray done at that time was normal. General examination, baby was lethargic, responsive to stimulus, poor feeding, icteric up to legs, no pallor, cyanosis, edema, lymphadenopathy. Vitals was stable. Respiratory rate was 68 per minute, tachypnic. Peripheries were warm. Peripheral pulses were well felt. Capillary refill time less than 3 seconds. Saturation 98% under 20 CPAP. Head-to-toe examination was normal. No caput, no cephal hematoma, no subgaleal bleed. Anterior fontanelle at level 3 cross 3 centimeters open, and no facial dysmorphism, no cleft lip or no cleft palate, no dysplastic ears or low set ears. Umbilicus was healthy, no discharge or erythema, normal female genitalia, spine and hips limbs were normal. Systemic examination on admission, the child grunting was present with mild subcostal retractions. Other systemic examination was normal. Child was lethargic, responsive to stimulus. Mild hypotonia was present. Deep tendon reflexes were present. Neonatal reflexes such as sucking, rooting, and grasp reflex was weak. On admission, CBG was low with RBS less than 20. Hence, the baby was started on 10% deep bolus, followed by which started on maintenance fluids. Baby was also empirically started on IV antibiotics, piptaz, and amikacin. On VBG showed high anion gap metabolic acidosis with an anion gap of 24, and initial pH was 7.010. First line investigations done, serum electrolytes showed anion gap of 20. CBC showed neutrophilic leukocytosis with a total count of 28,620, neutrophil predominant. CRP was positive, 10.4. Serum ammonia was mildly elevated, which was 206 milligram per deciliter. Blood cultures were sterile. Urine ketones done was negative, and ultrasound cranium done showed no intracranial bleeding. CSF analysis done was normal, and nil RBCs or WBCs were found. CSF culture showed no growth. Lactate done on 42nd hours of life were mildly elevated, which was 23. Serially, the baby was monitored for pH and serum ammonia, which showed no further worsening. Subsequent course in hospital, baby developed neonatal jaundice and was on phototherapy for 4 days. After 96 hours of admission, respiratory distress gradually settled and the baby was weaned off to room air. Baby was started on IV fluids and gradually established direct breastfeeds and stopped from IV fluid support. Baby did not have seizures during the entire course of hospital stay. So initially, we suspected sepsis, ruled out sepsis because blood cultures were sterile. Forelimb saturation was normal and bedside screening echo was normal, and ruled out congenital cyanotic heart diseases. Since CSF analysis and biochemistry was normal, ruled out meningitis, suspected EEM, and further evaluation was done. Plasma ammonia, which was sent, first sample sent, showed was mildly elevated, 206. Child had low glucose, ammonia was mildly high, lactate was increased with high anion gap metabolic acidosis, and ketones was negative. So the possible differential diagnosis we thought of was fatty acid oxidation defects, glycogen storage disorder and gluconeogenesis defects, mitochondrial disorders, organic acidemias, and urea cycle defect, which was ruled out because ammonia was only mildly elevated and further glucose was normal. Child was serially investigations were sent, showed normal, mildly elevated alanine levels. Organic acid analysis were normal urine organic acid profile. Acyl carnitine profile were within normal limits. And whole exome sequencing subsequently sent showed fructose 1,6 bisphosphatase deficiency or disorder of gluconeogenesis. Both parents were also found to be heterozygous carrier by genetic analysis later. Approach to hypoglycemia. So when a baby was admitted with hypoglycemia, we look for acidosis. If acidosis is present with lactate, increase in lactate, we suspect gluconeogenesis enzyme deficiencies. With increased ketones, we suspect glycogenosis deficiencies and cortisol and GH deficiencies. But we did not send further growth hormone and cortisol levels because further hypoglycemic episodes were not there. In case of no acidemia, with decreased ketones and increased free fatty acids, we should suspect fatty acid oxidation defects. And with decreased ketones and decreased free fatty acid, hyperinsulinemia has to be suspected. So discussion about the basic biochemistry. So in carbohydrates, we have monosaccharides such as glucose, galactose, and fructose, and polysaccharides such as glycogen. So the glucose is the primary substrate of energy, which is available through normal dietary intake, through gluconeogenesis and glycogenolysis cycles. So as when during a fasting state, initially the glucose is derived from glycogenolysis up to 24 hours. Once this glycogenolysis is depleted, then the body accustoms to gluconeogenesis, which is glucose derived from amino acids such as alanine and other substrates such as lactate, and glucogenic amino acids such from alanine, and glycerol part of fat, and propionyl CoA. So this is the basic glycolytic pathway and gluconeogenetic pathway. In glycolytic pathway, the glucose is converted to broken down into pyruvate. And in gluconeogenesis pathway, this pyruvate is converted to glucose. So in this pathway, we have fructose 1,6 bisphosphatase enzyme, which helps in the conversion of fructose 1,6 bisphosphate to fructose 6 phosphate. This is the alternate substrates where gluconeogenesis happens. So if glycogenolysis is depleted, the body accustoms to gluconeogenesis further. So glycogen stores from the muscle is converted to glucose and lactate, and the lactate is released from the muscle, which is taken up by the liver, which undergoes gluconeogenesis further and gives glucose to the body. And alternatively, similarly, alanine from the muscles will also get converted to glucose via liver via the gluconeogenesis pathway. So this is the basic Cori cycle and glucose-alanine pathway, also known as Cahill cycle. Fructose 1,6 bisphosphatase deficiency impairs the formation of glucose, not only from all gluconeogenic genetic precursors, but also from the fructose. This is the basic fructose metabolic pathway, where fructose is converted to fructose 1-phosphate via fructokinase, and it is converted to glyceraldehyde and glyceraldehyde 3-phosphate. So this glyceraldehyde 3-phosphate in well-fed state will undergo glycolytic pathway, whereas in a fasting state will undergo a gluconeogenetic pathway, where fructose will go in a gluconeogenesis route. So fructose 1,6 bisphosphatase deficiency is a disorder of impaired gluconeogenesis inherited in an autosomal recessive manner, predominantly involving the mutation in the gene encoding fructose 1,6 bisphosphatase on chromosome 9q22. So far, they have reported 150 cases. And nearly half of the affected infants will present in first 4 days of life due to deficient glycogen stores. So this is a case report from Malaysia where they have reported 7 cases. And another case report from a pediatric age group patient. So molecular etiopathogenesis is fructose 1,6 bisphosphatase deficiency impairs the glucose production from all gluconeogenic precursors, including fructose. So mainly euglycemia and FBP1 deficiency depends on glycogen stores in liver. So once if this glycogen stores in liver gets depleted, and in another catabolic states such as fasting or in minor such as vomiting, diarrhea, these glycogen stores will get depleted and the alternative gluconeogenic substrates will come into action, where pyruvate, alanine, and glycerol accumulates and should get converted to glucose. But because of this fructose 1,6 bisphosphatase deficiency, this will all get accumulated. So conversion of pyruvate into lactate and acetyl-CoA also leads to lactic acidosis and ketosis. Deficient conversion of glucose 1-phosphate to glucose will also activate the pentose phosphate pathway, which is responsible for the production of purines and pyrimidines, which further results in hyperuricemia. Clinical features in an acute crisis, the baby infant can present with hyperventilation, apneic spells, seizures, coma, which is commonly seen in neonates and infants. Other features are irritability, tachycardia, hypotonia, and hyperhidrosis. Hepatomegaly can be there along with transaminitis. Between the crisis periods, the infant can be uneventful with normal development and growth. Trigger episodes has to be explained to the parents, such as fever, fasting, decreased oral intake, or vomiting infections. Ingestion of large amounts of fructose, around 1 to 2 gram per kg per day, also can trigger acute episodes. In untreated individuals, catabolic state leads to multi-organ failures, especially liver, brain, and heart. In several patients, they have also reported sepsis, blindness, and Rey syndrome. So preliminary investigations we do is complete blood count, blood culture to rule out sepsis, serum electrolytes to look for dyselectrolytemia, blood gas analysis to look for high anion gap metabolic acidosis, and CBG monitoring for hypoglycemia, urinary ketone levels, and CSF analysis and culture to rule out meningitis. Secondary investigations are serum lactate, which can show lactic acidemia, hyperalaninemia, ketosis, elevated glycerol 3-phosphate, hyperuricemia, and increased free fatty acids. The confirmation test for fructose 1,6 bisphosphatase is genetic testing, where we look for FBP1 mutation. So management during acute illness, patient must not be given any forms of fructose or sucrose. As many oral medications can also contain sucrose and sorbitol. So we should make sure only sugar-free medicines are given to these patients. On admission, careful clinical assessment, GCS monitoring, and blood pressure monitoring has to be done. Following tests like VBG gases, glucose monitoring, electrolytes, complete blood count, lactate, and blood culture has to be taken. And we should treat any infection during acute illness in such child. Initially, we need to identify the clinical status of the child, whether we can treat it via orally or in an IV route. Orally means in infants 0 to 1 years, we usually can secure an NG tube and start on glucose polymer concentration at 10 grams per 100 ml at 150 to 200 ml per kg per day. And as the age group increases, this is the guidelines. And in IV route, we have to, in acute hypoglycemic episode, we can give 2 ml per kg of 10% glucose over a few minutes, and followed by a normal saline 10 ml per kg bolus can be given. If the baby is found to be in shock, we can give a bolus of about 20 ml per kg. And further, we have to calculate both the deficit and maintenance for this child and correct the hypoglycemia with 0.45% saline and 10% glucose. We should keep on rechecking the electrolytes every 24 hours if the child is on IV fluids. And as early as possible, the baby has to be started on oral or enteral feeds if clinically tolerated. If the initial pH is less than 7.1 or subsequent pH is deteriorating rapidly, or if the base deficit is still more than 15 millimoles per liter, we need to administer sodium bicarbonate. During the correction of blood glucose, if the baby is found to be hyperglycemic more than 8 millimoles per liter, we have to start on insulin infusion. Baby has to be reassessed after 4 to 6 hours, and as I said, reintroduction of oral feeds as soon as possible once the child is clinically stable and with no episodes of vomiting or loose stools. Prevention of primary manifestations, we have to prevent further hypoglycemia by avoiding fasting and consuming frequent meals. Slowly absorb carbohydrates such as uncooked cornstarch should be mixed in milk or water at bedtime and can be introduced to children after age 6 to 12 months who have nocturnal hypoglycemia. Uh, Parents has to be counseled about what all food items that has to be avoided in these children, especially foods containing fructose, sucrose, glycerol, or sorbitol, such as fruits, honey, and oral medications containing sucrose and sorbitol. Although small children can tolerate small amounts of fructose up to 2 grams per kg per day. Very important is genetic counseling has to be offered to the parents, where FBP1 pathogenic variant, whenever is identified in a family member, prenatal and pre-implantation genetic testings are possible. Follow-up surveillance throughout the growth. We have to follow the developmental milestones, neuropsychological development, and regular anthropometric measurements in each visit. Because repeated episodes of hypoglycemia can affect the intellectual can lead to intellectual disability, and neuropsychological testing has to be therefore monitored regularly. These are some of my reference articles. BIMDG guidelines for fructose 1,6-bisphosphatase deficiency. Thank you.
So, thank you all, and thank you for this session to present this case. So this interesting case we want to bring about because there was a two sibling death, and that was a consanguineous marriage couple, and unexplained death on day 2 of life in the family members. This baby was kept in NICU, but on full feeding, but he developed some fast breathing and acidosis, and hypoglycemia was there. At that time, we thought, maybe AG baby, this was a 3 kg baby. The previous baby was 2.7 kg, 40 weeks, that was a SGA. So we thought maybe any transient causes and initiated IV fluid, but what was striking was the metabolic acidosis with high anion gap. So with history of previous two sibling it, we evaluated the baby fully for the organic acidemia or hypoglycemia. Or what was the reason for hypoglycemia we evaluated, and the routine metabolic profile, so we did only after full feeding establishment by around day 6 or day 8 of life after achieving full feeds, so that organic acidemia profile and was normal. Unfortunately, we could not collect the sample for blood ketone evaluation at that time. So initially on day 2 when he presented with acidosis, maybe the urine ketone dipstick was negative, but so our biochemists were telling mostly beta hydroxybutyrate will be picked up by urine, and acetone and acetoacetate will require a blood sample only. So maybe if any subsequently, maybe we can look at sending blood samples for ketone level assessment. That was one that was we could not do in this baby. So if it was done clearly, we could have pointed out that is a gluconeogenetic defect and easily evaluated. But the final conclusion we could arrive only by doing the metabolic testing and genetic testing. The genetic testing was finally conclusive. And most importantly to note here, that is a easily treatable condition of hypoglycemia with only IV fluid. If IV dextrose is given with before baby goes for any MODS, any systemic illness, the outcomes are very good. And unfortunately, around 30 to 40% only may present in newborn period. So majority of them may present at 6 months or 8 years. Once sugar and fruits and all is introduced, they may present with hypoglycemia, acidosis. So sudden they may go for sepsis-like illness with severe or, liver failure, renal failure also. So maybe this also has to be kept in mind in other age group. And in newborn period, because fructose 1,6-bis-40 is needed for gluconeogenesis, and mostly newborns are dependent on the liver storage in the initial days for glucose management. So because that enzyme is not there, they go for acidosis, and we need to keep a close watch in this population when any sibling death and all is there. So that was the main reason for presenting the case. And with the diet modification and the intercurrent illness management, especially again with fever, that sugar containing, so the event of any stress, infection, any sugar containing syrups and all may be aggravating, because if it contains more than, especially newborn period or in infancy period, our weight is only around 8 kg, 10 kg. So if the 5 ml syrup has around more than 5 ml of sugar, na, sucrose, na, baby can develop acidosis because of that also. So that medication also we may have to take care on the follow up for such babies. Yes, any questions?
Well presented, sir. Sir, one doubt, sir. Now, why the child presented child was on breastfeed,
Yes, sir.
but still why they
Yes, sir, that is
fasting?
good. The thing is, so the milk output maybe in the initial few days may be very minimal, and cholesterol mainly has uh, 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 what to tell that biology, to priming the gut priming role more of this sweet. So
Baby will
yes,
be in
baby,
fasting.
yeah, most of the time this is a term baby 3 kg baby. The previous baby was an IUGR. We can tell they presented early because liver stores are gone. Again, in newborn period, in the first 2 days, the sugar management in the baby is mainly dependent on liver stores, and not on the mother's milk usually, because the cholesterol mainly only around 50 to 100 ml per day. So that has mainly a gut priming role, and this one rather than nutrition. But the importantly, when they go for around after 6 months, 1 year, they may have to give that what prescribed. They may have to give corn starch, maybe just like any GSD, any type 1 GSD. We may have to give some corn starch night to prevent hypoglycemic episode, fasting hypoglycemia in night times.
Sir, thank you, sir. Very good presentation, actually, very elaborate and detailed one. How can we differentiate this from the so-called common GST type 1? So, with regards to presentation.
Yes, sir. Thank you, sir. Again, GSD type 1, I don't think that is a close differential diagnosis only, sir. Only way confirmatory will be by genetic testing. But hepatomegaly, here also we will get hyperuricemia, because the alternative pathway will be there. So almost it is a close differential diagnosis only, sir. So mostly
Treatment,
confirmatory.
again, the same starch diet kind of thing helps for GST type 1
Yes,
also.
sir. Yes, sir. Yes, sir. GST is a close differential diagnosis for this condition, sir. Only by genetic testing, I think we can confirm, because hyperuricemia, hyperalbuminemia, all will be there in a GSD also, because there also the alternative pathway, there is glucose deficient. Here also there is glucose deficient. So other alternative pathway are same, almost biochemically, I think it is very difficult to differentiate, sir.
Okay. This on GST might also present little early as well as late. This HFI can also present at a later date, right, sir?
Yeah, yes, sir. GST, yes, sir. Maybe case reports are there in a newborn period. Yes, sir. They can also present, sir. But hepatomegaly and all was not there for this baby. But subsequently, when feeds and are introduced, they can go for hepatomegaly, and transient hepatitis can be there in late presentation, especially in infancy. They have told hepatomegaly and LFT abnormality with enzyme elevations they have reported in the late infancy, sir.
Right, sir. Thank you, sir.
Thank you, sir. Thank you.
Thank you for the excellent workup, Dr. Azima and Dr. Ashok. If there is no further questions, then we can go for the next presentation.
Thank you for such a detailed Thank you for such a detailed presentation. So next we'll move on to the next presentation from Chettinad Hospital and Research Institute by Dr. Shanmuganathan on late onset hyporegenerative anemia in an infant with RH isoimmunization, a rare presentation, moderated by Dr. Shaktivel KS. You can start presenting, please.
Am I audible?
Yes, you are audible.
Okay.
You're audible, but it's echoing. Just find out if there are any other system which is switched
Okay,
on.
sir.
Please mute it.
Okay.
Yeah.
Good afternoon, all. Good afternoon, all. This is Dr. Shanmuganathan, pediatric postgraduate from Chettinad Medical College. So my case is on late onset hyporegenerative anemia in an infant with RH isoimmunization, a rare presentation. So Master Y, a 56-day-old male child, second born of non-consanguineously married parents from Medavakam, came with complaints of yellowish discoloration of eyes and skin since birth and came for admission in view of worsening of pallor. So hence I would like to start from antenatal history. Maternal details, blood group A negative, booked and immunized, non-consanguineous marriage. Paternal details, blood group O positive. That's in 2019, the first pregnancy, it was an IUD with the baby's blood group of O positive. Anti-T was given on PND 5. In 2020, it was a normal vaginal delivery, girl baby. Baby's blood group was O negative, maternal ICT positive, alive and healthy, Anti-T not given. In 2021, MTP done at 6 weeks. In 2022, MTP done at 8 to 10 weeks due to personal reasons. In 2023, there was a spontaneous first trimester miscarriage. In 2024, coming on to the recent pregnancy, first trimester, spontaneous consumption, folic acid taken, dating scan and NT scan were done and it was normal. No history of fever with rash, radiation or drug exposure. ICT was positive. In second trimester, quickening felt at 5th month. No history of GDM, PH, thyroid disorder. USG Doppler was done, which showed MCA PSB 1.25 mmol. Third trimester, continue to perceive fetal movements. No history of GDM, PH. And growth scan done at 34 weeks plus 1 day. Estimated fetal weight was 2,329 grams. MCA Doppler was 1.52 mmol. With portal vein turbulent flow, thus suggesting fetal anemia. Hence, intrauterine investigations were done, which showed fetal hemoglobin of 6.4, fetal blood group A positive, and DCT triple positive. In 34 weeks plus 3 days, intrauterine transfusion was done with 100 ml O negative blood. Steroids covered. So post transfusion, hemoglobin improved to 16.5. So after birth, it was a term normal vaginal delivery, male child, birth weight of 2.73 kg, perinatal depression with APGAR of 6 on 10 and 9 on 10, required 1 cycle of bag and mask ventilation, no further respiratory distress. Investigation done after birth showed blood group of O negative. This is probably due to the massive intrauterine transfusion, and DCT was negative at this point, and hemoglobin was 9.8. Retic count was 1.9, which was low, and peripheral smear was normal. Total bilirubin was 5.6 and direct 0.5 and indirect 5.2. Phototherapy cutoff was 6. At 48 hours of life, investigations were repeated, which showed a hemoglobin of 8.8 and total bilirubin of 15.26 and direct 0.99 and indirect of 14.2 with a cutoff of 13.5. Hence, treated with phototherapy, and child was transfused with 15 ml per kg of O negative blood. On day of life 7, hemoglobin was repeat investigation done. Hemoglobin was 10.7, total bilirubin was 13.8, direct 1.1, and indirect 12.7. So on day of life 37, child was readmitted with complaints of yellowish discoloration of skin and progressive pallor. Investigation done at this point showed hemoglobin of 5.0, further fall, with retic count being 1.7 and bilirubin total 19.69 with an increase in direct fraction of 3.79 and indirect of 15.24. Sepsis workup done and it was negative. RFT, electrolytes, and TFT were normal. TOD screening was done. CMV, IgG, and rubella IgG were positive. Parvovirus was negative. USG showed no abnormality. So the child was treated with phototherapy, and 1 unit of PRBC was transfused at 15 ml per kg. Post transfusion, hemoglobin improved to 9.6. Pediatric hematologist opinion was obtained. Was suggested serial monitoring of hemoglobin and LDH, extended RBC phenotyping, and NGS for further hemolytic workup. In case of ongoing hemolysis, IVIG was part of the plan. Pediatric hepatologist's opinion was obtained in view of the elevated direct fraction. Child was started on UDCA and phenobarbital. In view of the possible need for IVIG, child was referred to a government hospital, where at day of life 40, child was further evaluated, and the blood group was O negative and DCT was negative. Hemoglobin was 8.9, peripheral smear was normal, and the corrected reticone was 0.76, with bilirubin being total 14.1, direct 3.1, and indirect 11. Evidence for and against hemolysis are anemia, significant elevated indirect bilirubin with a background history of RHICO immunization. Evidences against hemolysis are peripheral smear had no evidence of hemolysis, with the DCT being negative. Thus, no evidence of active hemolysis in the peripheral circulation. Hence, IVIG was withheld. So, coming on to the recent complaints, child was admitted here with complaints of yellowish discoloration of eyes and skin since birth, and parents noticed increasing worsening of pallor in the child, and child came to CHRA for further management. No history of pale colored stools, no history of refusal of feeds or decreased activity, no history of fever, cough, cold, no history of vomiting, loose stools, incessant cry. Child is on DBF, tolerating feeds well, passing urine and stools normally. Family history, no non-consanguineous marriage, no family history of TB, asthma, seizure disorder, no history of blood transfusions. Development history, child was developmentally normal, immunized at birth according to national immunization schedule. 6 weeks vaccine was not given at that point. General examination, child had significant pallor. Child had significant pallor and icterus. Vitals stable. Head to toe examination was normal. Systemic examination, per abdomen, liver was palpable 2 centimeter below RC, right costal margin. Liver span was normal for the age. So on day 56, child was admitted in CHRA with worsening of pallor. Investigation done showed further fall in HP, 5.6. RBC indices were normal. Peripheral smear was normal, with the normal platelet and WBC counts. And total bilirubin was 4.57 and direct bilirubin was 2.67, with LDH being 294 and CRP non-reactive, DCT negative. So no evidence of hemolysis in the peripheral circulation at this point. USG done at this point showed minimal sludge in the gallbladder, suggestive of inspissated bile. And CMV PCR done was negative. Fundus exam for CMV retinitis was negative. Parvovirus was negative. Iron was 212. Ferritin was high. This could be due to the repeated blood transfusion. And TABC was 234. Vitamin B12 was 215, and folic acid was 24.20. So, summarizing the case, there has been recurrent fall of hemoglobin with an initial clinical picture suggestive of immune-mediated hemolysis in the intrauterine life. the blood group was A positive and DCT was triple positive. Thus, in the background of RH isoimmunization with history of intrauterine transfusion. Further, later episodes of anemia, in the later episodes of anemia, there were no features of hemolysis in peripheral circulation, with retic count being low to normal and DCT being negative, thus suggestive of poor marrow response, and blood group of the baby was O negative. So thus pointing more towards the late onset hyporegenerative anemia secondary to RH isoimmunization. So the investigation showed fetal hemoglobin of 6.4, fetal blood group of A positive, and DCT triple positive. Hence, uh, coming to the approach to the neonatal anemia, in this setting, due to the decreased hemoglobin and Coombs test being triple positive, it pointed more towards the immune-mediated hemolytic anemia. And on the later episodes of anemia, it pointed more towards the hyporegenerative anemia. So, approach to a neonatal anemia is decreased hemoglobin concentration, then retic count has to be done. If it is low, then it points more towards the hypoplastic anemias and congenital infections and leukemias. If it is normal or high, then Coombs test is to be done. Coombs test, if it is positive, will point towards the immune hemolytic anemia. If it is negative, then MCV is to be done. If MC is low, then chronic intrauterine blood loss and alpha thalassemia syndromes are to be considered. If it is normal or high, peripheral blood smear is to be done. If it is abnormal, RBC intrinsic defects should be considered. If it is normal, then infections and blood loss could be the causes. So coming on to the discussion of RH isoimmunization, RH isoimmunization is a preventable disease in which an RH negative mother develops antibodies against RH antigens on fetal RBCs. These antibodies are generated by exposure of the fetal blood into the maternal circulation due to feto-maternal hemorrhage secondary to previous pregnancy, abortions, trauma, invasive procedures. Isoimmunization of RH negative pregnant women can be prevented by administering a prophylactic dose of anti-immunoglobulin. It neutralizes the effect of these isoantibodies. A failure or delay in prophylaxis can destroy fetal RBCs, leading to hemolytic disease in newborn, and is usually treated with phototherapy and exchange transfusion. RH isoimmunization is responsible for neonatal anemia, which varies in severity from early fetal hydrops in utero to mild to severe anemia during the immediate postnatal period. In RH isoimmunization, anemia can be present in three scenarios: early onset hemolytic anemia and two late onset types. The most common late onset types is the late onset hemolytic anemia, in which reticulocyte and bilirubin levels are elevated, bone marrow is active, and compensatory erythropoiesis occurs. The underlying mechanism for this is ongoing destruction of the mature RBCs. The treatment is IVIG and blood transfusions. Late onset hyporegenerative anemia, reticulocyte count is low or absent, bilirubin levels are normal, bone marrow activity is suppressed. Underlying mechanism being destruction of the RBC precursors and marrow suppression. Treatment is blood transfusion with plus or minus erythropoietin therapy and IVIG. So late onset hyporegenerative anemia. This is a less recognized consequence of hemolytic disease of fetus and newborn. Three mechanisms have been implicated: intramedullary destructions of RBC precursors, erythropoietin deficiency relative to the degree of the anemia, bone marrow suppressions from intrauterine transfusions. Uh, these are similar case reports published. So in this case, the child was treated with multivitamin supplementations as per the cholecystitis regimen, and child was transfused with 1 unit of PRBC at 15 ml per kg in view of hemoglobin at 5.6 gram per deciliter. On admission, continued on UDCA, folic acid, and multivitamins. After discharge, child was followed up regularly. Around 3 months of age, child's hemoglobin stabilized with no further fall, improving steadily. So latest follow-up reports, hemoglobin has been increasing steadily with DCT becoming double positive and blood group becoming A positive, thus suggesting the improvement in the bone marrow response. Thank you.
So I welcome Dr. Jalil sir, our IAP South Zone Vice President. Jalil sir. Jalil sir.
Sir, sorry, that was a net disconnect. That was a wonderful presentation by Dr. Shanmuganathan, the postgraduate. This we sometimes encountered. It's a nightmare. Those who are treating with newborn with jaundice or newborn with anemia. See, my one question is: all these repeated losses and repeated abortion like that in the history, the treating physician should know whether this infant, that is the fetus or the newborn, is sensitized or not sensitized. That is the most important question we have to answer. If you are dealing, I have done so many intrauterine transfusion with the Mediscan Dr. Suresh in Ramakrishna Hospital. We have done in utero transfusion and saved a lot of sensitized baby, especially due to RH isoimmunization. Even the platelet isoimmunization we have treated. I just wanted to know, because of the persistent hemolysis and persistent Coombs direct positive, first of all, we must know we are treating it with a sensitized fetus, sensitized newborn, subsequently the infant. I think the early administration of IVIG can be, you can have a trial on that so that the further sensitization, we can minimize that. Otherwise, the hypo-regenerative bone marrow, whether that bone marrow itself will respond to IVIG, I don't know. That's a comment I just wanted to know. We must know whether we are treating a sensitized baby or a non-sensitive. The treatment protocol for sensitization is different. The major anchor of treatment is IVIG, just to neutralize the antibody which is circulating in the mother and subsequently in the baby, that is causing the culprit. And slowly the indirect fraction is slowly coming to the direct fraction, where the direct fraction we have to, the management is entirely different, whereas the indirect fraction, it is easy to treat by phototherapy, easy to treat by IVIG, and the response is also good. Thank you very much. Wonderful presentation. Am I audible?
Presentation, sir. Yes, sir. Thank you, sir.
Thank
So
you.
wonderful presentation from Chettinad team. So yes, you told maybe probably the in vitro transfusion and all has contributed to RBC precursors were also maybe is suppressed because numbers because of RH sensitization in fetal life. And maybe as you told, the hemoglobin at birth was almost more than 12, some, no? Nearing 12 or 15. So maybe that also, yeah. So maybe adult RBCs are also transfused. Maybe that also have contributed to suppression of the precursors, because erythropoietin may be again suppressed. So that was a nice, wonderful presentation. And I think subsequently, as you pointed, baby improved by around a third month, fourth month, baby has improved. Yes. Thank you, sir.
Only thing is that in a clinical examination, you have not mentioned about the palpation of the spleen. Splenomegaly invariably there in any hemolytic process. It was not mentioned.
Wonderful presentation, but the clinical context is very strong here for RH isoimmunization right from the start. And how about exchange transfusion, sir? Why we didn't go for exchange transfusion, which persistingly the hemoglobin was dropping again and again? Could that have helped? That was one.
Yes.
And bilirubin was documented more in many instances. In hyporegenerative, how will be the bilirubin? Should it be elevated? And in one of the smear RBCs were lysed actually. How in regenerative RBC? I saw in one of the RBCs lysed picture was there. So, from the clarification.
Dr.
Good
Gayatri?
afternoon, Dr.
Yeah.
Gayatri. I'll be moderating this presentation. So, actually, even in the late onset hyporegenerative anemias, there may be hemolysis, but then the hemolysis is not that significant that it turns out in the peripheral blood. So, and since the baby also had some biliary sludge, so baby had direct fraction, which was more contributing to the hyperbilirubinemia. And also with the intrauterine transfusion postnatally, even though there was hyperbilirubinemia, that was always in the phototherapy level, which didn't require exchange transfusion. So, and the exchange transfusion as such was not given as a treatment option, or the late onset hypogenerative anemia did not cause that level of hemolysis to go to an exchange level, and the management explained was like basically by blood transfusions to temporarily maintain the hemoglobin, and also IVIG in case it is not getting if the recurrent transfusions were required, or if the erythropoietin suppression was contributing, sometimes erythropoietin supplementation was also mentioned as treatment option. But the degree of hemolysis was not that significant to cause exchange transfusion.
Intrauterine investigation and transfusion, could you throw us more light about?
Sir, the second pregnancy itself, like even though the baby's blood group was O negative, mother was by the time itself she was isoimmunized. By the time itself ICT was positive. So further pregnancies, she had two MTPs. So this was the first time the baby was getting exposed to those antibodies. This fifth pregnancy, the baby was blood group was found to be A positive. So, and since she did not receive any anti-D during her second pregnancy, there was more risk that this baby was sensitized, and baby as such had intrauterine hemolysis. So, during the serial scans, there was increased in MOM, and fetal anemia was also there, which required intrauterine transfusions. So, that was the antenatal part. However, there was no fetal edema or polyhydramnios. It was detected earlier. So earlier itself, the child had intrauterine transfusions. So what we have to understand is the advent of easy availability of these intrauterine transfusions. We expect that these presentations of late onset hemolysis is more to be uncovered in the following era, because we manage with intrauterine transfusions. The level of this double volume exchange transfusion might come down, but then they may have presentations like these late onset hemolysis or late onset hyporegenerative anemias.
Thank you for a wonderful explanation and such an insightful case presentation. If no further doubts, we'll move on to the next presentation from Dr. Kamakshi Memorial Hospital, presented by Dr. Divakar on a minimally invasive solution for vesicouretic reflex, the STING procedure, moderated by Dr. Prahada Ajay. Please start presenting. Chetina, can you please stop sharing your screen?
Good afternoon to everyone. Am I audible?
Yes, please start presenting.
Ma'am, is it audible, ma'am?
Yes, it is audible.
I'm Dr. Divakar. I am going to present a minimally invasive solution for VOR, the sting procedure. 4-year-old girl child presented with complaints of fever for 7 days, abdominal pain for 2 days, and vomiting for 2 days. History of presenting illness: 4-year-old female child came with complaints of fever for 7 days, which was associated with headache and abdominal pain and body pain. The child was admitted elsewhere and treated with IV ceftriaxone and referred here for further management. Past history: the child had one history of URI in the March 2024, and she had another history of febrile illness, which was diagnosed with the first episode of UTI on June 2024, which was culture negative UTI, and second episode of UTI was there, and in July 2024, both were managed conservatively. Birth history: antenatal history, it was a non-consanguineous marriage, it was normal conception, no comorbidities in mother, antenatal scans was normal, and there was no history of any antenatal hydronephrosis. Natal history: it was first child, term baby, appropriate for gestation age, birth weight was 2.7 kg, born by she was cried immediately after birth, breastfed on day 1, passed urine and meconium on day 1st, no history of any NICU admissions. Developmental history: head controls attains at 4 months of age, roll over at 5 months, sit alone at 7 months, walk alone at 11 months of age, and the child calls Amma Appa under 12 months of age. Vision and hearing was normal, and she is a developmentally normal child. No history of any developmental delay. Immunization history: she was vaccinated up to, according to age, up to IAP schedule. General examination: on arrival, child was alert, afebrile, and vitals was, heart rate was 130, tachycardia was there, respiratory rate was 36 breaths per minute, effortless tachypnea was there, BP was 114 by 68 mmHg, BP was within the normal limit, but peripheries were cool below ankle, pulse volume was 3 plus and 1 plus, CRT was prolonged, and saturation was 99 in room air. Anthropometry: weight was 13.8 kg, length was 101 centimeter, and head circumference was 94 centimeter, BMI is 13.5 gram per meter square. It was normal for anthropometry. Systemic examination: abdomen soft, no organomegaly, respiratory system bilateral larynx present, no added sounds. Cardiovascular system S1, S2 present, no history of any murmur. Central nervous system normal tone and power, bilateral pupil equally reactive to lights. Genitalia normal and no any history of labial synechia. Provisional diagnosis: acute febrile illness and septic shock. Investigation done, it's shown total count was 32,440 and hemoglobin was 8.8. Rest of the parameters was normal. And urine routine did found to have 15 to 20 pus cells per I power field. And CRP was 321.6 milligram per liter. It was positive. ESR was prolonged 90 mm. Other other febrile profile was negative. Investigation done, USG abdomen shows bilateral normal kidney, size was normal, no internal echoes were present, other solid organs was normal, trace of free fluid was there. CECT whole abdomen done, there was bulky left kidney and multiple ill-defined hypoecho enhancing areas in the upper, middle and lower pole cortex of both kidneys was there, bilateral perinephric fat standing, and few bilateral renal hilar nodes, future suggestive of binatal acute pyelonephritis, left-sided more than right side. Mild hepatomegaly was there, cystitis was there, and minimal interbowel free fluids was noted. This is the CECT image showing heterogeneous opacity in the right left kidney and mild on the right side is noted. Final diagnosis was recurrent urosepsis for evaluation, bilateral pyelonephritis, septic shock, and anemia. Treatment given. Treatment was started with airway, O2 via HFNC was started. IV fluid bolus was given and IV maintenance was given. In view of septic shock and recurrent shock, we started on dopamine infusion and antibiotics was upgraded to injection meropenem and we given for 10 days. Bladder was catheterized and pediatric surgeon opinion done. and advised to continue culture sensitive antibiotics for 10 days. And we planned for MCU and DMSA after 4 weeks of treatment. Child was discharged with Septron and Folivit and planned MCU and DMSA after 4 weeks. This is the video showing MCU. In scout phase, there was loaded colon. In filling phase, there was normal bladder contour. So it's suggestive of primary VUR. And in filling phase, there is a reflex present in the left side. So it was a low pressure reflex. In voiding phase, there was grade 3 VUR was there. And right side, no obvious VUR there. And bladder contour was normal, urethra was normal. Post-void, no residual dye. Impression of the MCU, left-sided VUR, grade 3 and low pressure reflex. This is the video showing MCU. In filling phase, there was reflex in the left side. And voiding phase also, there was reflex in the left side. And at the end, we noted mild on the right side also. The right side also, we can notice this mild VUR was there, but its left side was predominant. And we did DMSA on the right kidney. The size was normal in shape and position. But there is a mild break in the contour in the upper pole of the right kidney, and the rest of the cortex was normal. Left kidney, the size was smaller but normal in position. Lower of the kidney shows severely impaired traces uptake and with irregular cortical outline. The rest of the kidney shows relatively preserved extraction of the radio tracker. The residual function of the right kidney was 71% and the left kidney was 29%. This is the image showing DMSA. This is the right kidney showing mild break in the contour of the upper pole. Left kidney affected on the both side. Both poles are affected and the size was also reduced in left side compared to right. Diagnosis, final diagnosis is bilateral primary VUR, left side more than right side. And management options, we planned for continuous antibiotic prophylaxis and ureteric implantation was planned, lap are open, and with endoscopy deflux injection, the string procedure we are planned. This is the cystoscopic image. The left side showing laterally placed ureteric orifice with H2 configuration, that is moderate opening of the ureteric orifice with patulous orifice. Right side showing mild H1 configuration with patulous orifice. Bladder mucosa was normal, urethra was normal. Procedure notes, we did under LMR GA with caudal block, patient in lithotomy position, 7.5 French cystoscopy was introduced, endoscopic injection of Dexel, that is hyaluronic acid done on both sides below the ureteric orifice by double it technique, that is hydrodistension injection technique of 0.8 ml of Dexel was injected on the both side, and adequate amount of volcanic mount we achieved and the bladder was empty. This is the video showing the procedure. Hydrodistension injection technique, we are going through the ureteric orifice and we can note the H2 configuration on the left side. The needle is inserted and we injected once in the intrarenal. The deflux was injected in the intrarenal, a double technique by one injection, and we back came and we injected another injection in the ureteric orifice. After the injection, we achieved that adequate volcanic mount of distension on the both sides. Follow-up protocol, we advised to do USG plus or minus MCU after 3 months and DMSA after 1 year of age. So we came to vesicoureteral reflex. This is the retrograde flow of urine from the bladder up into the upper urinary tract, most common congenital anomaly of the urinary tract. It is a single most treatable cause for the recurrent pyelonephritis in children because it's the most common cause of reflux nephropathy, and it was approximately 30% of younger children with their febrile UTI have VUR. This is the grade of VUR. It has 5 grades. Grade 1 showing the reflex was there, but it's into the non-dilated ureter. And the second one was reflux into the renal pelvis. And grade 3 was mild to moderate distension of the ureter. Grade 4 was moderate, and grade 5 was gross dilated ureter was there till the renal parenchyma. Types of urea: primary VUR reflects in the presence of normal bladder control function and no underlying obstructive pathology. Secondary VUR is due to any underlying pathology and with associated anomalies, any congenital anomalies. Natural course of VUR, it can be spontaneous resolution also, but in high chance, in younger children, low grade of VUR, normal kidney and DMSA, no lower urinary tract infection, the spontaneous resolution chance was high. It was low in older children, high grade VUR, grade 3 to grade 5. There is no low chance of spontaneous resolution, scarred kidney and DMSA, and presence of lower urinary tract dysfunction. Long-term consequences: renal damage caused by recurrent UTI have long-term consequences such as hypertension, proteinuria, FSGS, and chronic kidney diseases. Diagnosis of VUR by MCU technique and radionuclide cystography and DMSA. In MCU, we can find out the grades of VUR. In DMSA, we can identify the scars and the grading of scars we can identify, and the percentage of kidney damage we can identify. Medical management: the main aim is to prevent the recurrent febrile UTI and renal damage and reflux nephropathy. So there is continuous antibiotic prophylaxis we can given. So conventionally, all grade of VUR are considered to start with antibiotics, and grade 1 and grade 2 are simply followed. Grade 3 to 5 are initially managed with continuous antibiotic prophylaxis. General indication for intervention: there is a persistent high grade VUR, breakthrough infections while on prophylaxis, limited renal reserve, and progressive renal damage, and significant VUR in the solitary kidney, VUR with other anatomical abnormalities. Interventions in VUR: the endoscopic materials used is D-Flex and Dexel, Vantris, and macroplastic. And injection techniques are hydrostatic distension implantation technique, that is single hit technique, and another is double hit technique. This is a video showing the double injection hydrostatic distension injection technique. The catheter was inserted. One injection was given on the submucous of the internal renal orifice, and another one is the outer ureteric orifice was injected. And adequate amount of volcanic mount was achieved. And this is showing original image of a double hit technique. And so what surgical interventions? Surgical intervention is used for the reimplantation of the ureter. There was two types, intravesical and extravesical. In intravesical, supratrigonal technique, infratrigonal technique, and cross-trigonal technique was used. In extravesical, only supratrigonal technique was used. And another is combined, and laparoscopy and robotic techniques are there. Follow with the child with VUR, endoscopic or open intervention, we have to do USG study plus study for the obstruction or reflex, and 3 to 6 months for the follow-up. All patients with long-term consequences to do annual checkup for hypertension, proteinuria, and renal function test. Thank you.
It was a good presentation, and we learned about sting procedure. It was good. But the question is like, what made the choice between giving a medical treatment of antibiotics versus this procedure? So why we didn't offer a antibiotic prophylaxis for this child? Why we straight away went for intervention? Any particular reason?
Sir, in DMSA, in left side, the scar was there, and the size of the kidney was reduced where compared to the right side. And she had a repeated urosepsis, and it was the third episode.
Achha,
So we
okay.
planned for the procedure, sir. Rather than antibiotic prophylaxis, we did for surgical interventions.
Shall I ask one question or a comment?
Yes, sir.
This is regarding the left kidney. One episode of URA followed by repeated urinary tract infection,
Yes,
and
sir.
one scan revealed a perinephric collection. That
Yes,
is very detrimental in any even in babies and adult. Any perinephric collection is detrimental for a salvageable kidney. So usually we do that. We remove the collection by placing a stent.
yes.
Is there any obstructive process in the upper tract? Leave
No, sir,
alone
there was
the
no any.
leave alone the vesico-ureteric reflex. All the procedures which you have described is a recommended one. As already mentioned, we should try a medical management. Then if it fails and you documented the renal scarring and the volume is lost, everything is there as a perfect complication of any urosepsis, especially in a girl baby now. This collection, what you have done, it is resolved on its own, or usually in adult, we used to place a stent to drain the collection. After some time, we removed the stent and will give by some time before the damage progress. What is your take on this?
The collection was removed, sir. We catheterized the bladder.
It is in the perinephric space, in the upper tract.
Yes.
Hello, sir. Hello, sir. This is Dr. Arun Prasad, sir. I am Dr.
Yes, sir. Yes, sir.
I'm the consultant in this for
Yes,
this
sir.
case.
Please, sir.
So in this case, actually, what we have done is initially we tried for antibiotic prophylaxis, antibiotics and IV antibiotics. When you ask about that perinephric collection, the bilateral pyelonephritis, which you have said. And we did try for, we were thinking about whether if the collection is quite high, we wanted to do an ultrasound tapping. But with the bladder catheterization and with the adequate antibiotic, it was resolving. So we didn't opt for any invasive intervention at that point. Since the child was clinically improving also within 48 hours of giving higher antibiotic, like meropenem was started initially, Piptas was given, and then meropenem was hiked after that. And since with the higher antibiotics, the child was improving, we didn't plan for any invasive intervention for this.
Already the left kidney started showing some scarring. Will this scarring will get resolved, or even after the corrective VUR surgery, what are you going to do to safeguard the left kidney?
It is permanent, sir. The scarring is always permanent, just like any other scar in any other part of the body. So what the purpose of doing intervention is that is the exact reason why you have done the intervention, sir. Initial two UTIs were already there, and which was managed by continuous antibiotic prophylaxis, just like the previous person who asked for the question. So we did try with the continuous antibiotic prophylaxis initially. Since the third one was very severe and pyelonephritis was there, and it was quite, and the DMSA was planned after that. Then by then it was quite late. So much of damage have already happened in the left kidney. Unfortunately, the scars are completely permanent and we cannot do much about it. But we have to save as much as possible of the nephrons so that the child doesn't end up with CKD as much in the long run. So to prevent the further reflux, we have to go for surgical intervention.
Exactly.
The point of
the message is the pyelonephritis. It's a medical emergency. We have to treat this aggressively. Our aim is to prevent the renal scarring. Invariably, this kind of a presentation, they will go for CKD in around 15 to 16 years, like that. Wonderful.
I have one. I'm Dr. Sanjeev from SRM.
Yes, sir. Please go ahead. Go ahead, sir.
Yeah, we have this BP of 114 by 68 or 70 something was recorded in this 4-year-old child, no? Which is in the hypertensive range. And there is a scarred kidney also. So were you giving any antihypertensives here?
No, sir, we didn't give antihypertensives at that point of time. And later on, after the child got recovered and we have all the serial measurements of BP was in a normal range. So we didn't have any need to start on antihypertensives. And we did get a nephrology opinion of the same. So they have also concurred with the same.
Okay, fine, right.
And from surgical point of view, I just wanted to add, the reason for presenting this case is, since this case is having multiple recurrent UTI and so much of scarring is present on both sides, particularly when you see the left side, it was like so severe. And when you have noticed that during the cystoscopy, the orifice is quite laterally placed as we have written in the OT notes. The laterally placed orifice is always dangerous, and the natural anti-reflex mechanisms will never be in place, and they will have more reflex on the side. That is why we were able to see the more scarring on the left side compared to that of the right side. The right side ureteric orifice was quite orthotopic, but it was still quite patulous. So we had to do the the injection on the both sides. The other alternative is to do a complete open surgery by opening a fan steel incision, and we have to go in through the bladder, and we have to do a complete ureteric reimplantation. So that would have taken like 7 days of recovery and placement of stents, and so much of pain and post-op follow-up and morbidity for the child. And in this case, this is like literally the daycare procedure. The child admitted today, and we have done the procedure, and the next day morning we discharged the child, and child was up and running within the evening of the surgery itself. So it's such a very minimally invasive procedure, just like a daycare procedure, and it was like complete permanent cure can be achieved with such a small procedure. But we only trick behind this is we have to carefully select the patient in this kind of cases. We have reserved these kind of surgeries to the grade 2 to grade 3 grade VUR people. Grade 1 obviously CAP is enough, and grade 4, grade 5 invariably they require higher mode of surgical interventions in general, and success rate is little less in case of deflux in grade 4 and grade 5. But they do have been tried, but success rate is quite less. So if we select the patients correctly, and if we give deflux in those kind of children, the results are amazing, and they just completely get cured, and we can absolutely arrest all the further kidney damage and the progression to the chronic kidney disease. That's a point I wanted to drive through by presenting this case.
What about follow-up, sir, in the case of sting procedure?
Yes, we will just follow it up with ultrasound initially, and at the end of 3rd to 6 months, we can do an MCU and we can confirm how much it has resolved. And the deflux is known to have around 80 to 90% of success rate if we have done double sting procedures. So which we have just done in this case, as we demonstrated in that animated video. So that is what we have done for this child. So the success rate is quite high. But still, there is definitely not as good as an open surgery. The open surgery is the gold standard one, absolutely, and it has almost a 98% success rate in open surgeries. Here, in case it will be like 80 to 90%. So we do have to do an MCU at the end of 3 to 6 months, and if it is cleared, we can let the child go. Even if not, it would have reduced the VUR the grade for continuously. I mean, absolutely, and probably it will be like grade 1 at the max, even if you have some VUR. For that, antibiotic prophylaxis, and the child, we allow the child to grow. Probably it will completely settle down when the child grows. And a DMSA will be doing it every yearly for next 3 years. So to look for any increase in scars with the baseline DMSA which we have already got, we'll compare the DMSA every yearly. For a minimum of 2 years, we have to do DMSA. If we don't have any increase in scarring, then we can leave the child alone.
Thank you, sir. It is nice to know such recent advances and innovations in, especially for VUR. If no further discussions, we can probably move on to the last presentation of the day from Sri Balaji Medical College and Hospital, presented by Dr. Geeta on MRSA bacteremia in a young child following mumps infection, moderated by Dr. Kritika, IP, Professor in Pediatrics.
Good afternoon, everyone. Okay, I'm Dr. Geeta, final year postgraduate from Sri Balaji Medical College. I will be presenting the case MRSA bacteremia in a young child following mumps infection. Coming to the case presentation, a 9-year-old boy came to our OPD with complaints of swelling of both sides of neck and cheek associated with pain on chewing food that lasted for 3 days and fever that lasted for 3 days. There was history of loss of appetite and lethargy since onset of fever, no history of vomiting, abdominal pain, difficulty swallowing, headache, or decreased urine output. The child was clinically diagnosed to have mumps and was treated with supportive treatment, antipyretics, and plenty of fluids at home. During history taking, we found that the child was not immunized against mumps. He had received only MR vaccine as per the national immunization schedule. This child then returned to our OPD due to persisting fever spikes even on the 7th day. The parotid swelling had reduced, however, and the child had no other systemic complaints pertaining to mumps complications like orchitis, aseptic meningitis, or pancreatitis. The child was hence admitted for further evaluation. On clinical examination, the child was conscious, sick-looking, had no pallor, no clubbing, cyanosis, or any significant lymphadenopathy. Vitals, the child had a pulse rate of 90 beats per minute, respiratory rate of 24 breaths per minute, and BP of 100/70. Head-to-toe examination and systemic examination were unremarkable. So we considered the following differential diagnosis. The first differential diagnosis we considered were complications of mumps, meningitis with or without encephalitis, or pneumonia, nephritis, pancreatitis, and other co-infections, possible co-infections like scrub typhus, enteric fever, or malaria. We did blood work for the same. Our CBC revealed neutrophilic leukocytosis and positive CRP and elevated ESR. And lab workup, we sent blood culture, Vidal, scrub typhus IgM, and peripheral smear for malarial parasites. Our blood culture was significant for MRSA growth after 48 hours of incubation. Other workups were negative. During the child's stay in the hospital, the fever spikes continued to persist. The child had around 2 to 3 fever spikes in a day. So we initially started the child before we received the blood culture reports on broad spectrum IV antibiotics like azone at 75 milligrams per kg per day. Despite this, the child continued to have fever spikes for 48 hours after initiating ceftriaxone. Meanwhile, our blood culture came back as showed growth of methicillin-resistant Staphylococcus aureus, which was sensitive to only doxycycline, ciprofloxacin, and clindamycin. Hence, we stopped injection ceftriaxone and started on oral doxycycline at the dose of 2.2 mg per kg per dose. The fever spikes then gradually reduced in intensity and frequency, and the child became afebrile on day 3 of oral doxycycline. This child was then discharged on the 7th day after partially completing the course of antibiotics, and he was told to continue oral doxycycline at home for another week. And he was found to be clinically well on follow-up after 1 week. Now, coming to discussion, mumps is an acute infection caused by a single-strand RNA paramyxovirus, which is mostly self-limiting, which transmits through respiratory droplets and saliva. Initially with parotitis and followed by fever and other constitutional symptoms. But complications in mumps are very rare. Immunization with MMR vaccine, especially in developed countries, has rendered mumps very uncommon. But in this unimmunized child, we would first suspect complication of mumps as one of the first differential diagnoses for prolonged fever after a mumps infection. So MRSA bacteremia in this young child was a rare finding. Why is this case novel? There is very limited literature or case reports of mumps and co-infection with other organisms. We managed to find only 2 or 3 reported cases. Rasti in 2016 reported mumps and followed by co-infection with enterovirus in about 3 or 4 children. And Mao and Doyle in 2023 reported an instance of mumps infection followed by viral myositis caused by Coxsackie A virus. This case report is the first of its kind, reporting MRSA infection following mumps. Coming to a conclusion, mumps vaccination has still not been included in the national immunization schedule. And there has been a steady rise in the incidence of mumps since 2021. In Tamil Nadu, in 2021, there were only 61 reported cases as compared to more than 1,000 cases in 2022 to 2023. And we've also had several case reports from various regions in India and Maharashtra, Uttar Pradesh, Orissa, and Rajasthan, all whom have reported increase in incidence of mumps over the last 4 to 5 years. And we had several outbreaks in 2023 in Idukki and Palakkad regions in Kerala, in Tamil Nadu, Karnataka, and Chhattisgarh. In addition, if a known disease follows an unpredictable course has complications associated with the disease, certain uncommon etiologies should also be considered. This underscores the importance of thorough clinical examination history taking. Thank you. Stop.
So this
Hello.
infection, MRSA infection, is the community acquired or hospital or a co-infection along with mumps?
Good afternoon to everyone, and thanks for IAP Chengalpet branch for giving us a wonderful opportunity. Sir, actually, we don't know. Just the child had mumps, and clinically, mumps would easily get self-limited itself by 5 to 7 days. But here, this child continued to have fever spikes. We really don't know whether it is community acquired. As far as we know, measles is the infection that causes significant immunocompromise, making the child susceptible to various infections. And we think, like the senior pediatricians can throw light. We think that the MRSA he would have got because of the immunocompromise caused by mumps. We really don't know. But since the child continued to have fever spikes even after the 7th day, we went ahead and did the investigations, and to our surprise, the blood culture showed the growth of MRSA. And after starting the antibiotics to which the MRSA was susceptible, the fever also abated and the child became clinically well. This could have been community like acquired MRSA also, but we don't know actually what is the cause.
Because the treatment of community acquired MRSA is very difficult.
Sir, I can't hear you properly, sir.
No, the treatment of community acquired MRSA, we have to be very careful because it requires a lot of planning, and the response to regular antibiotics is not that much encouraging. But my doubt is whether it is a co-pickup or incidental. Must be.
Maybe a co-pickup. The child was not an immunodeficient child, actually. Is a child with a normal growth. So we think it could be a co-infection or something.
Since it is a MRSA bacterial, and nowadays the mumps epidemic is there. Even in Coimbatore, we isolated a lot of mumps, those who have received the MR vaccine at the government level. We always confirm this mumps by doing PCR.
Okay.
And this is the only live virus, mumps virus, which will replicate directly to the neurons. We can easily demonstrate the virus in the CNS. So that this is the only virus, where all the other viruses, they have an indirect effect. And so we always do some PCR to confirm the mumps.
Okay, sir.
Of course, you have mentioned the clinical diagnosis. You have a very classical clinical find. No clinician missed the mumps if it is
because subsequently one more sibling also developed mumps in the same family.
Yes.
So this double confirmed it, and we just wanted to present the case because the senior pediatricians should advocate to the policymakers to introduce mumps vaccine along with MR so that this kind of outbreak doesn't occur.
It has already been stressed from IAP Tamil Nadu to include the MMR instead of to replace the MR. Even in central IAP, we stress the inclusion of MMR in place of MR. The policymaker has to understand the scenario. The mumps outbreak is devastating in our area also.
Yes, sir. The entire family is getting affected. Yes, sir. Thank you. Even the adult cases, we are seeing mumps nowadays.
Do you recommend vaccination for this child, MMR vaccination? At what age you suggest?
This child, maybe after 3 months, we can go ahead with an MMR vaccine, I believe, sir.
Yes.
Okay.
That's a message.
Yes. Thank you, sir. Thank you, IAP Chengalpet, for giving the wonderful opportunity.
Nice presentation, ma'am. Just one doubt, ma'am. Like in a case of bacteremia, we got it in the culture. So regarding the choice about IV antibiotics versus oral, how did you choose doxy?
Actually, the child did not have any vomiting or abdominal pain. So we thought first we will try with oral doxycycline. And if the child doesn't respond, we thought we'll just wait for 24 hours. And the child, just because he responded very well to oral doxy, we thought we'll go ahead and finish the course with oral itself rather than going in for IV antibiotics.
Okay.
Okay, thank you, ma'am. Thank you so
Thank
much.
you.
That was a nice presentation. Thank you, everyone, for joining today. Thank you, all our heads of the department, professors, faculties, postgraduates, and pediatricians of IAP Chengalpet, and especially Dr. Jalil Ahmed, sir, for joining us today and giving us so much insight and his knowledge, sharing his knowledge. I hope all of us can meet for the next meet in the next month, and we'll have similar active discussion just like this time. Thank you, everyone.
Thank you very much.